welcome. Today we are going to talk about depression. Depression is one of the commonest mental disorders with significant potential morbidity and mortality. But in our setting, we do not hear much about it, yet it contributes to suicide. Why is that so? One, culture. In our culture, we tend not to talk about how we feel or what we are going through. Two, one of the symptoms of depression is suicide, and suicide is a taboo in our culture. No one wants to be associated with a family that has anyone who committed suicide. So if someone passes on because of suicide, they will find another reason. And most people with depression tend to appear normal on the outside. It's not until you speak to them that you figure out what it is. What are the causes of depression or the risk factors? It is multifactorial and it follows the biological, psychological, and social model. Genetics do play a big role. Like all other mental illnesses, they are passed on through the DNA. Stressors in life, like chronic illnesses, hypertension, cancer, HIV, psychosocial stressors, loss of a job, loss of income, physical trauma, female gender are more at risk for depression. Poor interpersonal relationships, stressful life events. Depression also occurs due to abnormalities in neurotransmitters, especially serotonin. Individuals with depression have a reduced amount of serotonin. Psychologists also explain that depression is due to a disturbance in the infant-mother relationship during the oral phase, that is 10 to 18 months. So it's very, very important to have a proper relationship during this oral phase. How do these individuals present? They present with a sad mood for most of the day for more than 2 weeks. They're really, really sad, very unhappy. Nothing seems to work for them. In children, they tend to be irritable. They isolate themselves and they have a decline in school performance. Individuals lose interest in pleasurable activities. You find this individual who used to enjoy football, play football, they don't enjoy it. They used to listen to music, they don't want to listen to music anymore. They have changes in their weight and appetite. Individuals will tend to eat more than usual or less than usual. They have no drive to eat, and in the end, they're going to lose weight. They have lost the will to live. The very society, they feel nothing works for them, nothing in the world is going to work for them. They have a negative view of themselves, a negative view of the future, and a negative view of the world. They have a poor concentration. You find an individual who used to do a task for 5 minutes, takes you about an hour to complete the similar task. It's because you cannot concentrate. You tend to be forgetful. You forget basic things where you have put your key or your phone password or your ATM pin. You lose direction sometimes. Somatic symptoms. These tend to be the symptoms that non-specific and these patients will present to us or to the primary health care worker with these symptoms. Symptoms like constant headache. A patient has had headache, has taken painkillers, but nothing is changing. They have no energy. Quite a number of them have abdominal distress. Psychomotor agitation. They move slowly than they should have. Or retardation, they move slowly than they should have, or they're agitated, they're quite irritable. Feelings of worthlessness. The person feels there's nothing that can work for them. And all this goes on for 2 weeks. And it causes significant impairment in their functioning. Different types of depression exist. One is postpartum depression, which is seen in mothers who have given birth. Giving birth is one of the taxing activities, and you find that mothers with newborns tend to have postpartum depression. The other one is atypical depression. Atypical depression is the different kind of depression, where an individual, as usually we expect the person who is depressed, is unable to sleep. This one sleep longer than usual. They eat more than the usual and they gain weight. How do we investigate depression? There's no blood study, or there are no blood studies to confirm the diagnosis. But we do these studies to rule out organic causes. Studies like a complete blood count, thyroid function tests, HIV, liver function tests, or LFTs. How do we manage depression? Management of depression is a journey that takes a minimum of 6 months. And it follows a biopsychosocial model. Biologically, we put these patients on antidepressants every day for at least 6 months. They also undergo psychotherapy sessions. One is the cognitive behavior therapy. Remember, a patient who is depressed, they have a negative view of themselves, they have a negative view of the future, they have a negative view of the world. So we have sessions with them, at least 11 sessions, a session every week, to change their negative thinking. We also teach them interpersonal therapy. Individuals with depression tend to have poor interpersonal skills, so we teach them how to relate with other people. We also teach them how to solve problems. The other biological medication we use is what we call the electroconvulsive therapy. This is used for severe forms of medication. We pass electric current through the individual's brain and we induce a seizure. Once again, depression is a journey, so it's very, very important to involve every person in the patient's life, their spouse, their family, their caregivers. In the next episode, we shall talk about bipolar disorder. Thank you for watching and prioritizing your mental health.